Today is the second section of Biotransformation of Xenobiotics. So I'm Dr. Namitha. Yes. Before moving on to this session, I would like to recap the previous session, what we did. Biotransformation occurs in two phases. I would like to give an analogy for this, like how we get a presentation. So once the presentation is received, we unpack it. That is a phase 1 reaction. And then how we use it, that will be like a phase 2 reaction. So the unpacking of a drug is the phase 1 reaction, wherein the phase 1 reaction has hydrolysis, reduction, and oxidation. For hydrolysis, the enzymes involved are carboxyl esterases, cholinesterases, peroxygenases, prodrugs and alkaline phosphatase, peptidases, beta-glucuronidases, epoxide hydroxylases. And in the reduction phase reactions, we have azo and nitro reduction enzymes, carbonyl reduction enzymes, disulfide reductions, sulfoxide and N-oxide reduction, quinoline reduction, dihydropyrimidine dehydrogenase, dehalogenation, dehydroxylation, wherein MARC and cytochrome B5 reductase and aldehyde oxidase, the reduction reactions are involved. These enzymes are very important for the point of exam. You might get a choose one of these kind of questions from these. Coming to the oxidation, we have alcohol, aldehyde and ketone oxidation reduction system, alcohol dehydrogenase, aldehyde dehydrogenase, dimeric dihydrodiol dehydrogenases, molybdenum hydroxylases, xanthine oxidoreductase, aldehyde oxidase, amine oxidases, aromatization, peroxidase dependent co-oxidation, flavin monooxygenases, cytochrome 450, endogenous biomarkers of cytochrome P450, activation of xenobiotic by cytochrome P450, inhibition of cytochrome P450, induction of cytochrome P450, that is xenosensors. So these are all the phase 1 reaction. Phase 1 reaction includes hydrolysis, reduction and oxidation. Coming to the phase 2 reactions, that is conjugation. We have glucuronidation and formation of acyl coenzyme A thioesters, sulfonation, methylation, acetylation, amino acid conjugation, glutathione conjugation, thiosulfate sulfur transferase, 3-mercaptopyruvate sulfur transferase, and unusual conjugation reactions and phosphorylation. So this is a phase 2 reaction. Coming to this CYP enzymes, we have around 55 human CYP enzymes, which metabolizes xenobiotics, fatty acids and deicosanoids, steroidogenic compounds, bile acids, vitamin D, retinoic acids, and unknown compounds. These are all the enzymes. From this class, we'll see what are all the factors affecting the biotransformation of the xenobiotics. So the therapeutic efficiency, toxicity, and biological off-life is greatly dependent on the metabolism of the xenobiotics. So this factors are chemical factors, physiochemical properties of the drug, and biological factors. Physiochemical properties include the properties of the drug, and chemical properties, how the drug interacts with the receptor, and biological factors are the external factors like species, strain, and all. So coming to the chemical factors, we have induction of the drug metabolizing enzymes, inhibition of the drug metabolizing enzymes, and environmental chemicals. Biological factors include species difference, strain difference, sex difference, age, diet, altered physiological factors, and temporal factors. Let's see one by one. Coming to the physicochemical factors. So this is how the interaction of the drug interact with the drug metabolizing enzymes. This physiochemical factors are molecular size, shape, pKa. pKa is a pH at which drug is 50% ionized and 50% unionized. pH of the drug, that is whether it is acidic or basic, electronic characteristics, charges present on the xenobiotic, that is that is a total polar surface area. It is an overall measure of the number of oxygen and nitrogen atom that bind with the water by functioning as hydrogen donors or hydrogen acceptors. Lipophilicity of the drug, log P. Log P is a measure of lipophilicity of a non-ionized form of a drug. Log P is the octanol water partition ratio, that is the ratio of the concentration of a non-ionized drug in octanol versus the concentration of non-ionized drug in the water. It is expressed in the log 10 scale. Isomers are the drugs with similar chemical formula but differ in the chemical arrangement. Drugs with delayed recovery are weak bases. Like if the drugs are weak bases, they have a delayed recovery from the body. That means they accumulate in the body. Examples are diazepam, midazolam, etomidate. For this, pKa ranging from 3 to 6. Drugs which are potent analgesics are strong bases. Examples are morphine, fentanyl, ketamine, bupivacaine, lignocaine. For this, the pKa ranges from 7.5 to 8.5. Most commonly used drugs are weak acids. These are OTCs, paracetamol, propofol, atropine, thiopentone. These are weak acids. For this, pKa ranges from 7.5 to 11. Lacex and salicylic acids are strong acids. At the pH greater than pKa, acidic drugs becomes less ionized. Whereas at pH greater than pKa for basic drugs, they become more ionized as they accept the protons. Drugs crosses the membranes in the unionized state, so their pKa and the pH of the surrounding environment affect their rate of absorption. Hence, the acidic drugs will be more readily absorbed in the highly acidic stomach, whereas the basic drugs are better absorbed in the intestine, where pH is slightly higher. Let's see here how the acidic drugs act in the body. So once the acidic drug is taken, it enters to the stomach. So this black indicates the passive diffusion. So once it enters into the stomach by passive diffusion, because this is an acidic drug and in the stomach there is an acidic pH, it directly gets absorbed to the liver by passive diffusion. Also, it is uptaken by hepatic transporters like OATPs. And in the duodenum as well, it is absorbed from the passive diffusion and uptake by OATP transporters. So once it enters the liver, there it gets metabolized. So acidic drugs are metabolized by acid glucuronidation, amino acid conjugation with the help of CYP2C9 and CYP2C8 cytochrome P50 enzymes. Some amount will enter into the small intestine. This undergoes first pass metabolism and re-enters into the liver by intestinal uptake transporters, that is OATP. From the liver, again, it enters to the bile, wherein it gets converted into parent and metabolites both. Some of the drugs present as such, some of the drugs get converted into its metabolites and it enters to the small intestine, and again the circulation occurs. Some of the drugs get excreted in the feces, that is parent and metabolites. Some will enter into the systemic circulation, wherein it has a high plasma binding capacity. Blood to plasma concentration ratio is approximately 0.5 in acidic drugs. Once it is into the systemic circulation, after the utilization, it enters into the kidney. By glomerular filtration and tubular secretion, it gets excreted in the urine. After systemic circulation, when it is present in the tissue, it has a small volume of distribution. Most of it is present in the extracellular water. Whereas when it comes to the basic drugs, it enters to the stomach. Stomach, it is not absorbed. As is my voice audible?
Yes.
There is some disturbance, I think, from some other one. Okay. Uh, Once we take up the basic drugs, it enters to the stomach. Since it is a basic drug, it is not absorbed in the stomach. It enters to the duodenum. By a passive diffusion, it enters to the liver. In the liver, it gets metabolized with the help of flavin monooxygenases, monoamine oxygenases, UGT, NAT, CYP2DC, and CYP3A4 enzymes. Some of it gets absorbed from the small intestine and enters to the liver. In the same procedure, it happens, and then from the liver, it gets entered into the systemic circulation. This also has a high plasma binding capacity. Blood to plasma concentration ratio is approximately 1. This has a large volume of distribution, that is more in the tissues and less in the extracellular water. Coming to the chemical factors, we have induction of drug metabolizing enzymes. Induction of drug metabolizing enzymes means this is a phenomenon where increased drug metabolizing ability of the enzyme by a xenobiotic. That means it enhances the ability of the enzymes to metabolize the drugs faster. This is called enzyme induction. Then xenobiotics, which causes enzyme induction, are called inducers. Most of the inducers are generally lipophilic and they have a very long elimination half-lives. There are two types of inducers, phenobarbital type inducers and polycyclic hydrocarbon type of inducers. Coming to the phenobarbital type of inducers, examples are most of the drugs follow this pattern, and pesticides. These increases the rate of metabolism. Polycyclic hydrocarbon types, cigarette smoke and 3-methyl chloroethane. These also increases the rate of metabolism. We have certain type of drugs where they causes auto-induction or self-induction. That means they stimulate their own metabolism. Example for these are carbamazepine, meprobamate, cyclophosphamide, and rifampicin. Induction mechanism, that means more metabolism of the drug will occur by different means of routes, that is increased enzyme synthesis, decreased rate of enzyme degradation, enzyme stabilization, or enzyme activation. Enzyme induction results in decreased pharmacological activity of most of the drugs, increased activity of the metabolites, and they also alters the physiological status due to the enhanced metabolism of endogenous compounds such as sex hormones and steroids. Coming to the examples of this, there are certain inducers. They causes the drugs with enhanced metabolism. That means when the inducers are present, these drugs are metabolized faster. So when you take the barbiturates, coumarins, phenytoin, cortisols, testosterone, oral contraceptives are metabolized faster. Alcohol increases the metabolism of phenobarbital, coumarins, phenytoin. Phenytoin increases the metabolism of cortisols, coumarins, oral contraceptives, tolbutamide. Rifampicin, this increases the metabolism of coumarins, oral contraceptives, tolbutamide, rifampicin. Cigarette smoke, this increases the metabolism of nicotine and amino acidides. So there will be a drug-drug interaction. So this becomes a very important part in the investigation of a new drug. So when we are investigating a new drug, the metabolic qualities must be analyzed. So enzyme induction studies are very important to know the effective plasma concentration of concomitantly administered medications. Induction of CYP enzymes, typically CYP1A2, CYP2BC, CYP3A4 is measured in vitro following exposure of testicle to the human hepatocyte cells. These studies are commonly recommended by FDA and EMA. The main enzymes estimated are CYP1A2, CYP2B6, CYP2C8, CYP2C9, CYP2C19, and CYP3A4. There are some examples below. CYP1A2, the inducer, which is approved by FDA, we can use inducer omeprazole, and the non-inducer is flumazenil. Substrate is phenacetin and analyte is acetaminophen. For CYP2B6, phenobarbital flumazenil is a non-inducer and substrate is bupropion and analyte is hydroxybupropion. CYP3A4, the inducer is rifampicin. Flumazenil is a non-inducer, substrate is midazolam and analyte is 1-hydroxymidazolam. For other enzymes like CYP2C8 and CYP2C9 and CYP2C19, the same inducer can be used rifampicin. Indirect inhibition. Indirect inhibition occurs in two ways. One is repression, that is decrease in the enzyme contents, and another one is altered physiology. Repression, decreased rate of enzyme synthesis. For example, when we take ethionine or puromycin or actinomycin D, there will be a decrease in the enzyme contents. Rise in rate of enzyme degradation. When we take carbon tetrachloride, carbon disulfide, disulfiram, this increases the rate of enzyme degradation. Altered physiology, when there is a nutritional deficiency or hormonal imbalance. Direct inhibition is rapid and results in prolonged pharmacological actions. Some of the examples of enzyme inhibitors and the drugs with decreased metabolism are when the MOA inhibitors are taken, barbiturates and tyramine drug metabolism get decreased. When the coumarins are taken, phenytoin drug metabolism is decreased. Allopurinol decreases 6-mercaptopurine. And when PAS is taken, phenytoin and exobarbital metabolism is lowered. Coming to the drug-drug interaction, when we take two different drugs together, this may lead to toxicity of a prescribed drug or the reduced activity of a prescribed drug. Let's see what is substrate. Substrates are degraded by CYP enzyme system. Inhibitors, this will decrease the metabolism of the substrate and lead to the increased drug level or affect the substrates and may therefore lead to the overdose toxicity. Inducers, this will increase the metabolism of the substrate and lead to the decreased drug level or the effect of the substrate and may therefore lead to the subtherapeutic levels. So inhibitors, these causes overdose or toxicity. The inducers, they decreases the drug level and causes subtherapeutic levels of the drug. Shared pathways, if the two substrates are given together, they both use the same CYP enzyme for degradation. Hence, the enzyme system becomes saturated and cannot degrade the drug as rapidly as normal. But both drug levels rise in the body, which may possibly increases the toxicity. Coming to the examples for drug-drug interaction, substrate drug taken along with the inhibited drug. So, for example, simvastatin, which is a substrate for CYP3A4, taken along with the inhibitor of CYP3A4, this can cause higher than the normal levels of simvastatin, which leads to the increase in statin toxicity, which may lead to the bleeding disorder. Similarly, salmeterol, which is a substrate for CYP3A4, taken along with the inhibitor of CYP3A, that is clarithromycin, an antibiotic, which is usually used for respiratory infection. The salmeterol, it is used in the nebulizer. So when these two are taken together, this will cause higher than the normal levels of salmeterol and potentially causes toxicity, which may cause tachycardia or arrhythmia. Taking two substrate drugs together, taking erythromycin along with aminophylline causes decreased metabolism of both the drug, potentially raising the toxicity of each. The toxicity effects from aminophylline are probably more important because this causes substrate drug taken with inducer drug. That is, St. John's wort herbal is an inducer Taking this with a substrate such as protease inhibitors for AIDS will increase the metabolism of protease inhibitors, reducing its serum level and reducing its therapeutic effects. This may lead to pneumocystis carni complication and the patient may die. So there are different substrates, inhibitors, inducers and substrate for each enzyme. This is a long list of enzymes, substrates, inhibitors and all. This you can refer from C&D. I've just given the main enzymes which is present here. CYP1A2, CYP2AC, CYP2B6, CYP2C8, CYP2C9, CYP2C19, CYP2E1, CYP2D6 and CYP3A4. This you can use it as a reference, but to remember all of this thing is very difficult. Coming to the environmental chemicals, some of the chemicals which is present in the environment, they can cause enzyme induction and inhibition. Examples for enzyme induction are halogenated pesticides, that is DDT, polycyclic aromatic carbons, which is produced from cigarette smoke. Enzyme inhibition, that is caused by organophosphate compounds and heavy metals like mercury, tin, nickel, cobalt, and arsenic. Coming to the biological factors, we have species difference. The species difference occurs in both phase 1 and phase 2 reactions. Phase 1 reactions, it is both quantitative and qualitative variation in the enzyme quantity and their activity. Metabolism, coming to the example, metabolism of amphetamine and ephedrine. Let's see, in human and rabbits, it is metabolized using oxidative deamination, while in rats, it is metabolized by aromatic oxidation. Phase 2 reactions, this is mainly qualitative variation. This is characterized by either presence of or the complete lack of that of certain conjugating enzymes. For example, phenol excretion, this is excreted by glucuronidation in pigs. In cats, it is by sulfate conjugation. Also, birds utilize ornithine for conjugation of aromatic acids instead of glycine. Coming to the strain difference of pharmacogenetics, the enzymes influencing metabolic reactions are under genetic control. It differs between the species, strain of the same species, and these are attributed to the genetics of the individuals. Study of interspecies and intersubject variability in the drug response, which results in the variation in the rate of biotransformation, is called pharmacogenetics. The difference in the metabolizing ability can be controlled by monogenic or polygenic genes. Metabolism of phenylbutazone, difumarole, and antipyrin. For these, in identical twins, there is no difference in the metabolism of these drugs. Whereas in the fraternal twins, there are larger variations between the metabolism of phenylbutazone and difumarole. Difference observed in the metabolism of certain drugs among different races. This is called ethnic variations. The ethnic variation, the differences in the metabolizing ability may be monomorphic or polymorphic. Monomorphic is continuous and it is unimodal. This is observed in the entire population. That means if it is occurring in the humans, it is with all the humans. So, for example, human can acetylate PABA and PAS to a smaller extent. While coming to the polymorphic or discontinuous model, this is polymodal frequency distribution. This is observed within the population. That means it might be a difference in the race or in the different population. Example for this is metabolism of isoniazid acid by acetylation. There are two categories of acetylators. One is slow acetylators, one is rapid acetylators. Slow acetylators or inactivator phenotypes. These category of people, they can metabolize isoniazid acid very slowly. However, with the rapid acetylators, they can metabolize isoniazid acid very rapidly. So you can see it here, whites, the people of USA and Canada, there are at least like 45% slow acetylators and 55% of rapid acetylators. The blacks of USA, 48% of slow acetylators and 52% are rapid acetylators. Like this, Latin Americans, American Indians, Japanese, they have different acetylators. So hence the dose adjustment play a very important role in the isoniazid administration, as high levels of isoniazid can cause peripheral neuritis. Other examples for this ethnic variations are debrisoquinone, succinylcholine, phenytoin, dapsone, and sulfadimeide. Coming to the next factor, that is age. Newborns have a very immature enzyme systems. This can lead to the slower metabolism. That means when we take the example of caffeine, caffeine has a half-life of 4 days in neonates, whereas in the adults it's 4 hours. The major portion of the drugs get excreted in the urine in the newborns in an unchanged form. Hence, the conjugation with the sulfate is well established. However, the glucuronidation is very less established in the neonates. For this example is paracetamol is mainly excreted by sulfate conjugation in the neonates. The overdose might cause hyperbilirubinemia. Sulfonamides causes renal toxicity. Paracetamol leads to the hepatotoxicity. In contrast, the enzyme activity increases as age advances. That means the older infants can metabolize the drugs faster than the adults. Hence, this older infants, that is from 6 months to 12 years, they can metabolize the drugs very fast. Hence, they require larger doses. Like, for example, theophylline half-life is 2/3 of the adults in the old infants. Very elderly, in contrast to this, very elderly individuals may have a reduced liver function due to the decreased liver size, microsomal activity, and hepatic blood flow affecting the drug clearance. The next factor is sex. The hormonal difference can influence drug metabolism. Some enzymes show sex-specific activity. That is, alcohol dehydrogenase is more active in males. Sex differences are widely studied in rats. Male rats have higher drug metabolizing capacity, while the females have lesser metabolizing capacity. Hence, most of the toxicity studies are performed in the female rats, while human metabolizes benzodiazepine very slowly. Also, women on contraceptive metabolize number of drugs very slowly. Hence, we should be very careful while giving other drugs along with the contraceptives to the women. Coming to the next factor, diet and nutrition. Drug metabolizing ability varies according to the diet. So when you take the lower protein diet, the metabolizing ability decreases. In contrast, higher protein diet, it will increase the metabolizing ability. This is because enzyme synthesis is promoted by protein diet, and the increased amino acid levels in the blood leads to the conjugation of drugs very rapidly. Increased protein carbohydrate ratio increases the mixed function oxidase activity. Fat-free diet depresses CYP 450 levels, that is phospholipids. These are the main walls of the CYP 450. Hence, the fat-free diet depresses CYP 450 levels. Deficiency in vitamins, that is vitamin A, B2, B3, C, and E. And minerals such as iron, calcium, magnesium, copper, and zinc can impact enzymatic activity. Coming to the diet and nutrition, as I told before, the protein diet, the lower protein diet decreases the metabolizing ability, and the higher protein diet, it increases the drug metabolizing ability. Increased protein and carbohydrate ratio, this increases the mixed oxidase function activity. Fat-free diet depresses CYP 450 levels. The same way, deficiency in vitamins, that is A, B2, and B3, C, and E, and along with the minerals like iron, calcium, magnesium, copper, and zinc can impact enzymatic activity. Starvation decreases the glucuronide formation. Alcohol ingestion,
decreases the enzyme activity initially, followed by rapid increase. Certain foods like grapefruit, apple juices and orange juices, cruciferous vegetables can inhibit or enhances the enzyme function. This grapefruit, as we know, this has a high vitamins and nutritious. However, this has a lot of impact on the many of the drugs because this inhibits the major enzyme, that is CYP3A enzyme. Hence, this causes high levels of statins when it is administered along with the statins in the bloodstream, leading to rhabdomyolysis. When it is given along with the calcium channel blockers, the levels increases in the bloodstream, leading to hypotension. When it is taken along with the estrogen containing medications, that is contraceptive or estradiol, this increases the levels of estrogen, leading to increased risk of heart attack. When it is taken along with the immunosuppressants, this leads to renal toxicity, increases the level of certain blood thinners, leading to bleeding disorder. Other drugs like antidepressants, corticosteroids, antiarrhythmic medications, anti-cancer compounds should not be given along with the grapefruit. So there are some examples over here how to show that how it affects the fasted levels. I mean, when the animals are fasted, and how it is affected when the animals or humans are fed. So when it comes to the NSIDs, the major one is diclofenac. Uh, T max varies with the fasted levels and the fed levels. It is more in the fed animals or human. These are some of the examples to show the fasted level variations with the fed level variations. Absolute oral bioavailability is usually determined by comparing the systemic exposure to the parent drug following oral administration and intravenous administration with the dose adjustment. That means the dosage differs from route of administration. So when we take it orally, the most of the drug gets metabolized before entering into the systemic circulation. However, when it is taken intravenously, the bioavailability is 100%. So hence, to calculate the absolute oral availability, we have this formula 100 into AUC per oral into dose of IV divided by AUC IV into dose of per oral. Many a times, this absolute oral bioavailability is lesser than the 100%. This is because drug may be partially or completely insoluble in the gastrointestinal tract when it is administered orally. In this case, absorption of both parent drug and drug-derived materials, that is the metabolites, is less than 100%. Oral absorption may decrease with increasing in the dose due to the precipitation of the drug at high dose levels. This gives rise to then infra-proportional dose exposure. That means the drug is not absorbed properly. So the dose and exposure relationship is infra-proportional. Drug may permeate the membranes or pass between the cells with low rate of passive diffusion, and the drug is not efficiently transported by an intestinal uptake transporter. For this example is linaclotide. The target is intestine. This is to treat constipation and irritable bowel syndrome. This linaclotide has very low log P and very high polar surface area. This strongly disfavors the passive permeation in the gastrointestinal tract. Hence, this locally acts in the intestine to treat constipation and intestinal bowel syndrome. The third action for this is to have a lesser oral bioavailability is the first pass metabolism. So the drugs moves into the pre-systemic organs like liver, intestine, and lungs. Drug may permeate the membranes with high rate of passive diffusion or as a substrate for intestinal uptake transporter, but its intestinal absorption is restricted by one or more efflux transporters such as PGP. For highly soluble, highly permeable drugs, it gets easily absorbed, but the efflux by intestinal transporters can be saturated at high doses, which gives rise to the supraproportional dose exposure relationship. Altered physiological factors. That means during pregnancy or hormonal status or hormonal imbalances there, we'll see number of drug metabolizing ability is altered. Maternal drug metabolizing ability is reduced in the later stages of pregnancy. This is attributed to the high levels of steroid hormone in the blood circulation. That is, examples, chlorpromazine and pethidine metabolism is reduced in pregnancy or on contraceptive medications. Increased hepatic metabolism of anticonvulsants due to the progesterone present during the pregnancy. Hormonal status, pregnancy and endocrine disorders can modify enzyme activity. Steroid hormones affect the drug metabolism. Adrenalectomy, thyroidectomy, or alaxon-induced diabetes reduces the rate of metabolism. Stress-related changes, which causes increased level of ACTH, impairs the drug biotransformation. Other conditions like pathological conditions, wherein the disease conditions is prevalent in the body. When the liver diseases are there, hepatic impairment due to the hepatic carcinoma, hepatitis, cirrhosis, obstructive jaundice, this reduces the metabolism of the drug, leading to the drug accumulation. Kidney dysfunction, this affects the drug excretion, altering biotransformation pathways. Example, conjugation of salicylate, oxidation of vitamin D, hydrolysis of protein. When there is cardiovascular disorders, there is a poor blood circulation to the heart, liver, kidneys due to the congestive heart failure, myocardial infarction. This affects the drug distribution, metabolism, and excretion. For example, propranolol and lidocaine. Diabetes, glucuronidation is reduced due to the decreased availability of UDPGA. Coming to the temporal factors, even the circadian rhythm has much variations with the drug metabolism. Diurnal variations in the enzyme activities occurs with light and dark cycles. Enzyme activity is maximum during the early morning hours, that is from 6 a.m. to 9 a.m. in the early mornings, and minimal during the late afternoons by 2 p.m. to 5 p.m. This variation is due to the cortisol levels in the body, which is dependent on light and dark cycle. Chronopharmacology, this is the study of variation of drug response, which is influenced by the time. Chronokinetics, time-dependent change in the drug kinetics. The drugs which are affected by temporal factors are aminopyrin, hexobarbital, imipramine. This diurnal variation in the rats can affect aminopyrin and hexobarbital metabolism. Half-life of metirapone in rats is for 2.5 times longer in night than in the daytime. With all this biotransformation, this leads to bioactivation and toxicity apart from drug elimination. So formation of highly reactive metabolites from relatively inert chemical compounds which interact with the tissue to precipitate one or more of the several forms of toxicity such as carcinogenesis and teratogenesis. This is called bioactivation or toxicological activation. The reactive chemically unstable species, the capable of toxication, are broadly divided into electrophiles and free radicals. So when the xenobiotic is taken, the reactive metabolites are formed. These are classified into electrophiles and free radicals. Electrophiles, they covalently bind to the tissue and causes tissue necrosis, cancers, and mutation. The free radicals, they undergo peroxidation or oxidative degeneration of cell components. They causes mutations of the genes and they can cause teratogenic effects. Electrophiles are the species deficient of electron pair and are generated in the cytochrome P450. Carbon, nitrogen, and sulfur containing compounds can be metabolically activated to yield electrophiles. Example for electrophiles are epoxides, that is epoxides of benzopyrene present in the cigarette smoke, which can cause cancer. Other epoxides, hydroxylamines, nitroso or azoxy derivatives nitranium ions, elemental sulfur. Mechanism where this electrophiles can act on the tissues are electrophile can precipitate toxicity by covalently binding with the nucleophilic components of the cell, that is the macromolecules, proteins, nucleic acids, lipids, or to a lower molecular weight cellular constituents. Covalent binding of to the DNA is responsible for carcinogenicity and tumor formation. The body's defense against electrophiles is either inactivation by conjugation with glutathione, the most abundant cellular nucleophile with SH group. Tissue toxicity by electrophiles, hepatotoxicity, that means hepatotoxicity of paracetamol metabolites. The more number of, when the paracetamol is taken, this is getting converted into imidoquinone derivatives. Most of it is getting converted by conjugation with the glutathione. However, when the glutathiones are saturated, then the other imidoquinone, which is left free, they get covalently bind with liver tissues, causing liver toxicity or hepatotoxicity. Free radicals, species containing an odd number of electrons. Either positive, these are either positively charged, negatively charged, or neutrally charged. Free radicals are formed via NADPH cytochrome P450 reductase or other flavin containing reductase. Example for this are xenobiotics like quinones, arylamines, nitrosyls, and carbon tetrachloride. Some of the endogenous compounds also gives rise to the free radicals like epinephrine and dopa. Most of the free radicals are organic. They produce toxicity by peroxidation of cellular components. An important class of free radicals is inorganic free radicals such as hydrogen peroxide and superoxide anion. These are the oxidative moieties. They can cause tremendous tissue damage leading to the mutations of the genes or cancer. The potential toxicity of the free radicals is greater than that of the electrophiles. Cellular defense mechanism against these free radicals include control imposed by membrane structure, neutralization by glutathione, control exerted by non-enzymatic oxidant scavengers such as vitamin A, E, and C, and enzymatic inactivation of oxygen-derived free radicals. These are the defense mechanisms. Generation of reactive metabolites is indicated by modification in the enzyme activities, formation of glutathione conjugates, and depletion in the tissue levels of glutathione. Since the availability of glutathione in the body is determined by the threshold of toxic response, thiols can be used to treat poisoning like paracetamol poisoning can be treated by N-acetylcysteine, which can yield the reactive metabolites. This decreases the reactive metabolites. So some of the compounds and their metabolic reaction that can generate toxic intermediates. Benzopyrene, metabolic pathway is aromatic epoxidation. This leads to lung cancer. Aflatoxin B1, olefin epoxidation. This leads to hepatic cancer. Thalidomide, hydrolytic cleavage of lactams. This causes teratogenesis. Chlorinated hydrocarbons, metabolic pathways, oxidative dehalogenation. This causes nephrotoxicity. Some of the drugs which have been withdrawn from the market also, and some of the drugs, they can carry black box warning for idiosyncratic hepatotoxicity. Examples are mentioned here: benoxaprofen, bromofenac, iproniazid, nifodazone. These are the examples for idiosyncratic hepatotoxicity. These are due to the production of reactive metabolites. Some more examples are here. So once the metabolic activation of the xenobiotics is there, reactive metabolites are produced. Acidic drugs, they undergo You, they undergo
We have right. She Himalaya.
different reactions and causes liver toxicity. When it is a basic or neutral drugs, they can cause either liver toxicity or CYP inactivation or blood dyskaryosis. Yes. I'm going to end the session faster. This much I have given the basics. Any doubts on this?